nous, la galaxie. صباح الخير. Good morning. Is the
Good
sound?
morning, Doctor.
Yes, thank you. Good morning. Dr. Rahim, Dr. Dupac.
Good morning.
Yes.
Yes.
Okay, are you ready? Okay.
Yes, yes.
Okay, you have 15 minutes. Okay. Dr. Dupac, I need you to do today the whole case summary till the treatment options and the retention protocol. Okay. In 15 minutes. Okay. You and Dr. Rahim. ليلى هتشتغلي معاهم ها؟ Okay. Dr. Rahim, are you here?
Yes, yes, yes.
Okay, you have 15 minutes to start the case, okay? Okay. See you in 15. When you need the next slide, please say next, and I will switch it for you. Time is up. Dr. Rahim,
Yes, ma'am.
please give me a brief summary of this case.
YA 9.5-year-old male patient, fit and well, complaining of difficulty in biting, complicated with class 3 incisor relation on a class 3 skeletal base with average slower anterior facial height, complicated with negative overjet and a class 3 incisor relation with concave profile with posterior bilateral cross bite, with a concave profile and competent lips with reduced incisal show. And the IOTN of this reveals the features of the IOTN reveals it's 4M.
4M.
Yeah.
Okay. Dr. Nassim, could you please give me extra oral assessment? Dr. Rahim,
Yes.
extra oral assessment, please.
Anterior anthropos, the external features, the 5 photos, the 3 photos taken in the natural head position, the profile rest, frontal rest, and frontal smiling. Photos reveals that the anteroposterior assessment, the zero meridian line, considering the zero meridian angle of convexity, and the Kettle's method shows the patient is having a straight profile, and the vertical parameters, considering the rule of third, FMPA shows the average horizontal growth pattern. The transverse assessment, the facial midline, rule of fifth, bird view and worm view shows there is no obvious transverse discrepancies. The soft tissue parameters shows the lips are competent with the lower lip is ahead of the E line and the normal nasolabial ankle and the shallow mentolabial sulcus, and the maxillary the increased nasolabial fold and the decreased visibility of the incisors and the malar deficiency shows that the maxilla is deficient, which are the signs of the maxillary deficiency. The buccal corridor is increased and the smile line, the lower lip smile line is reduced. The upper smile line is reduced and there is a decreased incisal show of the upper incisors. And the patient is having a non-consonant smile because of the lower lip line is in the reduced. Lower lip line is in the below the lower incisor region.
Excellent, Rahim. Excellent. Okay. So what is natural head position?
Natural head position is the relaxed head position of the patient when the patient is in the complete occlusion with the perfect bite.
And what are the types of natural head positions? The methods of natural head positions?
It's of there are 2 types of natural head position. One is sensory method and one is crude method.
Excellent. And what is the most accurate method?
Which one, ma'am?
What is the most accurate method?
The sensory method.
Excellent. Okay. You have mentioned that you are going to assess AP by 3 methods. What is the angle of convexity?
Angle of convexity is done by the Arnett angle of convexity. Yeah. This is the angle between the NA line and epoch line.
Glabella, huh?
Yeah, this is the
Okay, this is the
glabella
second.
to the
This
subnation. Yeah,
this the second time you didn't take.
glabella to the subnation
Yes.
and the subnation to the
Go ahead.
uh,
Bogoni.
pogonium.
Yes, and when the angle is
The angle is between the class 1 angle is like between 5 to 15 degree. In the class 2, it will be more than 15 degree, and class 3, it will be less than 5 degree.
just a second.
The negative values is suggestive of a prognathic mandible, and the positive values are suggestive of the prominent maxilla.
Okay. And okay. Excellent, Rahim. How to localize the trachea points in both the patients?
That is the vertical. It is divided from the hairline to glabella in order to assess the vertical rule of thirds, vertical assessment.
What are the 6 signs of maxillary intrusion?
There will be obtuse nasolabial ankle. There will be scleral show, paranasal malar deficiency, reduced incisor show at rest, flat nasal bridge. Yeah.
Okay.
Reduced incisor show yeah.
What is Frankfurt mandibular plane angle?
It is the line drawn from the uh, uh, posterior border of the mandible to the FX plane.
And
The lower border of the mandible. And it is estimated by intersecting the angle at the point of, normally the angle will intersect at the occiput. If the angle intersects in front of the occiput, it is suggestive of a vertical growth pattern. And if it is intersecting behind the occiput, it is suggestive of a horizontal growth pattern.
excellent. You have mentioned that the one method of the transverse assessment will be the facial midline, okay?
Yes.
Yes. Do you know any other types to determine the facial midline?
Facial midline from the glabella to the philtrum, where the line is dropped from the interpupillary line, and from the philtrum to the menton, whether the line is coinciding together linear.
How to assess soft tissue?
The soft tissues are the soft tissue assessment is done by the lip competency, then the lip prominence, lip length, nasolabial ankle, and the smile line and buccal corridor.
What are the factors that affecting nasolabial angle?
The maxillary nasolabial angle, the proclination of the incisors. It is divided into skeletal, dental, and soft tissue. The skeletal parameters shows the discrepancy between the maxillary and mandibular position. The dental is depending on the proclination of the incisors, and the soft tissue is based on the lip thickness and the upturn or downturn nasal philtrum.
Okay. How to measure the lip length? What are the methods you use to measure the lip length?
The lip length can be measured by from the stomion to the vermilion superioris.
Hmm?
The upper lip length is.
What are the factors that affecting the upper lip line?
The elevation of the upper lip during smile. It will be determined by the vertical maxillary axis or the anteroposterior positioning of the maxilla mandible and the lip length.
What is the etiology of the gingival height discrepancy?
What is the?
What is the etiology behind the gingival height discrepancy? An equal gingival level of the teeth. What is the etiology behind it?
Attrition of the teeth, the eruption pattern of the incisors, the proclination of the incisors,
okay.
Altered gingival, altered eruptive path, incisal wear, gingival hyperplasia or gingival coverage to the incisor region.
Okay. Let's assume that patient had a deviated chin. Okay?
Okay.
Let's assume that patients have a deviated chin. What you are going to check first?
The midline.
Okay. Could you please give me intraoral assessment?
The intraoral assessment revealed by the 5 photos reveals that the patient is having a almost fair oral hygiene, and the patient is in a mixed dentition stage. The lower occlusal photo shows all the permanent teeth from 6 to 6 except the 5s are present, and the deciduous second molars are present on both sides, and the left deciduous canine is also present, and the upper occlusal photo shows that the teeth from 6 to 6 are present except the 5s and 3s, and the 5 and upper right 5 and upper right lateral incisor are erupting, and the patient is having a moderate crowding. And the right buccal and left buccal shows left buccal photo shows that patient is having a class 3 incisor relationship with a reverse overjet of more than 3.5 millimeter with a posterior cross bite, and the midline shift is present towards right by 3 millimeter.
Excellent. And could you please interpret this radiograph for me?
This is the orthopanogram OPG of a mixed dentition stage, presenting all the teeth are present from 6 to 6 on both arches, and the deciduous teeth present are upper canines on both sides and lower second molars on both sides, plus the lower left canine is also present, and teeth erupting, the eruptive stage of the teeth are upper canines, upper second premolars and upper second molars are in the eruptive stage, and lower second molars, lower both second premolars and lower left canine is also in the eruptive stage, and all the third molars
You
or
can
have
upper left 5 here, okay? Upper left
space.
5, it's not erupted.
It's
Why?
not a space is deficient.
Excellent. Do you consider it as impacted or not?
It's impacted.
Actually, it's not impacted because we have no root maturation.
Space.
That we have no maturation. If the root is completely matured, okay,
Okay.
it will be impacted. Okay.
Yes, 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 yes.
Interpreted this video graph for me.
This is a lateral cephalogram
Mhm.
and the skeletal parameters shows that the maxilla is backwardly placed, which shows a value of 78 degrees with a normal mandibular position.
Start your answer with this is a lateral cephalometric radiograph. I'm going to talk about skeletal AP, vertical dental, CVM, and soft tissue. Okay.
Okay.
Okay. Start. Repeat once more.
It's a lateral cephalogram, and I'm going to reveal the skeletal, dental, soft tissue, and CVM of this patient. The skeletal parameters shows that the maxilla is backwardly placed, which shows the value of 78 degrees. And A and B is also suggestive of the maxilla is backwardly placed with an average lower face height. And the maxillary incisor is, the dental parameter shows that the maxillary incisor is proclined. And mandibular incisors are slightly retroclined.
What is the CVM patients?
CVM shows CVM 1, CVM 1,
1,
2, CVM 2,
1 or 2 like.
CVM 2.
Okay, CVM 2. Okay. And how much gross remaining in this area?
30%.
30?
I'm not clear. I mean, I cannot recollect regarding that.
Okay. What is
Can
the
treat by
problem
max.
nest here? What is the problem nest here?
The problem list consists of the anterior crossbite and the
Problem nest.
pathologies consist of the anterior crossbite. Sorry, the skeletal parameters shows that, yeah.
Pathology, skeletal, dental, and soft tissue. Okay, and don't forget the oral hygiene in the first place. Okay, you need to be more systematic. Okay.
Generalized uveitis, class 3 skeletal pattern with a bilateral crossbite, and the dental anterior crossbite, class 3 incisor relationship, bilateral posterior crossbite also, moderate crowding of the upper anteriors. The nasolabial angle is obtuse and
what is the aims and objective here?
maintain the oral hygiene, the growth modulation, in order to correct the deficient maxillary growth, correct the anterior crossbite, correct the midline, and correct the posterior crossbite, align the upper and lower teeth in the arch, and get a good buccal interdigitation by correcting the posterior crossbite, coordinate both the arches, and retain the correction by the end of the treatment.
Okay, excellent. What is the treatment planning here?
First, we have to refer the patient to a oral hygienist to get the oral hygiene measurements done. And second, the treatment can be done in 3 phases. The first phase, we need to refer the patient to a oral hygienist. The second phase is considering is again divided into 2 phases. First, we need to correct the skeletal discrepancy by the growth modulation therapy. And once the growth modulation therapy by the reverse pull headgear and the reverse pull face mask with the RME should be done to correct the transverse and the anteroposterior discrepancy of the maxillomandibular skeletal relation. And once the skeletal discrepancy is corrected, the second phase of the orthodontic treatment with the MBT prescription or O22 or O28 slot fixed appliance therapy should be done to correct the dental malocclusion. And by the end of the fixed appliance therapy, the retentive phase should be done with the fixed bonded appliance over the upper 2 to 2 and lower 3 to 3, and a vacuum foam retainer also should be given to retain the corrected position.
Thank you, Rahim. Your 15 minutes is up, okay? You have done well in the diagnosis part, okay? We need to recheck some points with you once more. I'm going to do it in a bit, okay? But you need to fast a little, you need to talk a little bit faster, okay? I didn't manage to ask you any questions related to the treatment planning, okay? You need to be a little bit more faster, okay, to be able to ask you in the treatment planning, okay?
Okay.
This time, actually, I'm going to ask you later on in the treatment planning and everything related to the rapid maxillary expansion and face mask and so on, but I need you to be a little more faster. I need you to answer the diagnosis part, all of it, not in 15 minutes. I need you to answer it in just 3 or 4 minutes, okay? You know the correct answer and you answering properly, okay? But you need to be a little bit fast, okay?
Oh.
Okay.
Thank you.
Okay. You have mentioned that you are going to use the face mask, right?
Yes.
And rapid maxillary expansion.
Yes.
Okay. What kind of maxillary expansion? What kind of rapid maxillary expansion? Bonded or banded?
Bonded.
Bonded. Okay. And what is face mask?
Face mask is a reversible headgear in order to correct the class 3 skeletal pattern, in order to facilitate the maxillary growth.
And what are the types of face mask?
Petite face mask, Delaire face mask. I know only these two, Delaire and Petite face mask.
Thank you. Layla, when to use the face mask? Layla? Dupek, when to use a face mask?
When there is an anteroposterior discrepancy or increased vertical discrepancy.
Excellent. And what are the contraindication to use the face
For,
mask?
if there is an increased vertical dimension, the face mask must be, the high pull face mask can be used to control the increased vertical dimension, but if the cannot recall.
Okay, could you please tell me what are the difficulties you may face during wearing the face mask to the patients?
Difficulties. I mean the patient's difficulties.
Mm-hmm.
The patient might, if the patient is not wearing it properly, it might lead to slippage.
Okay, thank you, Dupek. Laila,
Yes.
is it necessary to wear rapid maxillary? Is it necessary to wear? Is it necessary to wear the rapid maxillary expansion? Face? Would you please meet? Okay.
Yes.
Okay. Is it necessary to wear the rapid maxillary expansion with the face mask?
Yes, especially if we have a crossbite, it's necessary to do both.
What is the effect of the face mask?
We have skeletal, dental, and soft tissue. Skeletal, we do maxillary in a more forward position, and downward and backward of the mandible. And dental, we do lingual tipping of the lower incisors and proclination of the upper incisors. And the soft tissue, we increase the nasolabial angle.
Okay. What is the side effect of face mask?
Side effect? Maybe there could be anchorage loss. Because after we procline the upper teeth, there could be some anchorage loss.
How to control the challenging of the face mask?
No, I don't know.
How to consolidate after using the face mask? After you're finishing, how to consolidate?
We can use the face mask as it is on night time, or we could do a reverse twin lock appliance.
Okay. Could you please tell me the limitation of the using of the face mask?
We cannot pass 10 years, and he has to be CVM2.
CVM2, okay. What are the instruction you would give to the parents and the patients after you recommend face mask?
So he has to avoid any sports in the school that will hurt him. Also full-time wear.
For how long?
Till 6 months, and sometimes we can extend more than this according to the case. And we keep it hygienic, we clean it, and increase motivation for the patient because it's hard for young patients.
Okay. What are the retention challenging?
Retention?
Yes, you may face.
we have to maintain the positive overjet that we gained. Um, and retainer, maybe? I'm not sure.
How to control deepening the bind?
Using posterior bite blocks. And elastics, class 3.
What is the magnitude of force and the direction of force?
We use 350 grams, I think, right? I'm not sure. From 1 to 2 weeks.
1 to 2 weeks. Okay. And the direction of force?
It's 30 degrees, the elastics.
Thank you, Layla. Rahim,
Yes, ma'am.
how to minimize the proclination of the upper labial segment?
Upper labial segment during the
During the using of the face mask, yes. We already have procline upper labial segment to maxillary plane. It's 114. So how you are going to minimize the proclination that will happen during using the face mask?
we can use hybrid hyrax by incorporating the hybrid mini screws along with the
Where you are going to place this many screws?
in the palatal region of the maxillary incisors.
Okay, excellent. What else?
Then we can do the capping of the incisors. I'm not sure.
Okay. Where the hook should be located in the face mask?
At the center of resistance region between the premolar, the force should be directly passing through the center of resistance of the maxilla.
Okay, could you please tell me what are the mechanism of nasomaxillary complex?
Mechanism in the sense, like I didn't understand the question.
Mechanism of growth of nasomaxillary complex?
I cannot recollect.
Okay, what is the limit for camouflage in class 3 cases?
If the IMPA IMP is 85 degree,
Okay.
is less than, yeah.
Okay, what is class 3 incisors?
If the lower incisor relation is ahead of the centroid of the upper incisor,
When the lower incisor what?
cingulum
Yes.
or centroid. Centroid also is, I've read some books. Cingulum plateau or centroid, something like that.
Okay, saying when the lower incisal edge occlude anterior or posterior to the central plateau of the upper.
The lower incisor centroid anterior to the occlusal plateau of the upper.
What is the prevalence of class 3 cases?
3%, 3 to 5%.
Which mandibular position should we use during the assessment of class 3? ICP or RCP?
RCP.
And which position of cephalometric you should recommend when you're doing the cephalometric analysis, RCP or ICP?
I cannot recall it now.
Okay, what is RCP?
Retruded cuspal position.
Included cuspal positions, okay. And what is the etiology behind the class 3 cases?
The etiology can be skeletal discrepancy, skeletal, dental, and functional. The skeletal can be due to the discrepancy between the maxillary position and maxillary and mandibular discrepancy in the position, and maxillary and mandibular discrepancy in the size also. The dental can be due to the dental crossbite or the size of the maxillary and mandibular discrepancy in the size and position of the dentition. And the functional also can be due to the occlusal interference or of functional.
How to differentiate between the pseudo class 3 and the true class 3?
If the patient is asked to in the retruded cuspal position, the patient will be having a class 1 skeletal base, whereas in the whereas if it is a pure class 2 skeletal base, in the retruded cuspal position also, the intercuspal position also, the patient will be having a class 3.
When to refer the patient to orthodontic surgery?
If the patient is having a true skeletal class 3, the patient is advised for the orthodontic surgery, which cannot be where the growth is ceased also.
What is the meaning of camouflage treatments?
It is the acceptance of the skeletal discrepancy and correcting the dental over the skeletal discrepancy.
And what are the indications to do camouflage treatment in class 3 cases?
If the main this thing should be given to the patient, acceptance of the facial profile, whether if the patient is happy with the profile, we should not advise for surgery. After the cessation of the growth, and if the severity of the skeletal discrepancy is less, we should not advise the patient to go for the orthodontic surgery.
Okay, thank you. You have mentioned that this patient is going to wear rapid maxillary expansion, right?
Yes.
What are the protocol of the rapid maxillary expansion?
See, the patient, the rapid maxillary expansion appliance is advised to correct the posterior crossbite and to facilitate the action of the face mask during the orthopedic correction. Mainly the posterior crossbite, how much to activate the hyrax is assessed by the measurement taken from the buccal cusp to buccal cusp of the upper posterior teeth and the lower the difference between the upper cusp tip to upper mesiobuccal cusp of the upper maxillary teeth and the buccal groove of the lower mandibular teeth. The difference is taken into account, and 1.6 mm is added to that for the males and for the females, and 1.2 is added to males. Along with that, 2 to 4 mm is also added for the overcorrection. In case if there is no posterior crossbite, ultramec method is introduced in order to facilitate the face mask action.
What
Here,
are the protocol of using rapid maxillary expansion? What will you do once there's a patient? Tell me the clinical steps of the rapid maxillary expansion.
the upper and lower impression is taken and is sent to the lab. And once we receive it, we will show the patient's parents how to activate the hyrax screw. And the hyrax is cemented to the posterior teeth. Once we receive it from the lab, it is cemented to the posterior teeth, and the pre-activation is done by 2 turns. And the patient is instructed after the placement, there will be a pain, discomfort, and there will be a slight diastema formation. And we should convince the patient that the diastema will close spontaneously. And we advise the patient to turn the screw 2 turns per day till the next hole. Like once we activate till the next hole appears, they need to turn the screw, and we need to show that in the before fixing in the dentition. And we should show the it's better to keep a string or a tie over the key so that in order to avoid the swallowing of the activation key.
Okay. Thank you. What is the normal gingival health gingival looks like?
Normal gingival. I didn't get the question clearly, ma'am.
Okay. If you have a severely retrocline incisor, what it will lead to?
There will be root prominence in the cortical plate.
Mm-hmm.
And root prominence will be there.
Okay. What are the approaches used to reduce in the negative overjet?
What? Can you repeat the question, ma'am?
What are the approaches used to reduce the negative overjet?
We can proclaim the approaches to correct the reduced overjet. First, if the patient is assess the patient whether the patient is in the growing stage or the skeletal correction is completed. Depending on that, the modality of treatment should be planned. If it is due to the skeletal discrepancy. The skeletal discrepancy should be corrected in order to.
Rahim, just to give me a few seconds, please. I'll be back. So, Rahim, thank you for the participation. You have done well, but you need to study the face mask and the class 3 once more, Rahim. Okay?
Okay.
Okay, let's do it together. Okay? You have done the summary. Good. All the diagnosis, you have been through it. So good, but excellent actually. Okay? When I ask you this question, how to localize the trachea point in the bald patient, I'm not asking you what is the importance of trachea point. You don't have to tell me that it's using in the vertical assessment when the patient's in profile rest, okay? Trachea point here means the hairline, okay? In bald patient, he has no hair. So how you are going to determine the trachea point, okay? You ask the patient to frown, okay, or to get more sad. And when he does that, the last wrinkle appear in the forehead. This will be the trachea point, okay? And once more, you need to memorize the definition of the angle of convexity because this is the second time you failed to give me the answer. And also you need to memorize where it starts and where it ends. From glabella, subnasal, subnasal, Burgundian, okay? And class 1, when the profile is from 5 to 15, class 2 more than 15, and the class 3 is less than 5, okay? The sixth sign of protrusion, you have done it well, and I like how you stated in your extra oral assessment. Okay, this was very genius of you. Okay, and the rest you have it quite well. And yes. What are the factors that affecting the nasolabial angle? And this is the second question. You failed to give me the answer. First of all, nasolabial angle is the angle between the columella and the upper lip. It should be from 90 to 110, and it gives me the indication of the lip supporting by the upper incisor inclination. What are the factors that affecting it? Okay, first of all, the orientation of the columella, AP position of the maxillary incisor, inclination of the upper labial segment, and the AP position of the maxilla and the upper lip morphology. So when we talk about factors here, you have to give it a skeletal, dental, and soft tissue. Okay, skeletal will be the AP position of the maxilla, dental, dental will be the AP position of the maxillary incisor and also the inclination of the upper labial segment. Soft tissue will be the columella orientation and upper lip morphology. Okay, be organized in your answer, all of you. You have to mention the factors, the etiology, the anchorage in 3 planes. Okay? Is it clear?
Yes.
I just said it yesterday, Rahim, at the early morning, how to measure the lip length. We have 2 methods. Linear measurement, which is done by Dr. Arnott, which stated that the female will be from 20 to 22 millimeters, male will be from 22 to 24 millimeter, and the other method is the relative lip method. And I actually have another one, the relative lip method, the lip length method. This is the 2 commissary line to the philtrum, okay? Whereas the philtrum height is 19 to 22 millimeter. And number 3 will be the lips to lower anterior facial height. When we explained it yesterday, and we have mentioned that the face is the 1/3 from tracheum to glabella, glabella to subnasal, subnasal to the menton, okay? And the last one here, we are dividing into 2 thirds. 1/3 contain the upper lip, and the other 2/3 contain the lower lip and the chin, right? Right, Rahim?
Yes, yes, yes.
Okay. What are the factors that affecting buccal corridor? You have mentioned 12. The third question, you failed to give me the answer. What are the etiology behind the gingival height discrepancy? Okay, the unequal gingival height between the teeth. Okay, it will be due to the increased lip elevation on the smile, or increase the vertical growth of the maxilla to be more downward. Okay, it will give me also the unequal level appearing in the gingival heights, tooth attrition, as you said, ankylosis, delayed maturation of eruption, periodontal disease, and severe crowding. Okay, you have to mention all of the reasons, Rahim, in the exam. And this question, I told you, assume this patient has a deviation in his chin. Okay, what you are going to check first? Okay, in the panoramic, we are going to look after the wisdom teeth to see the size of the ramus and the condyle. Okay, and do we suspect something? Hemimandibular hypoplasia and hemimandibular elongation. Of course, we are going to check for the midline and the canting. Okay. And this is your assignment for today. You are going to tell me what is the difference between hemimandibular hypoplasia and the hemimandibular elongation, you and Dupek. Okay? And give it me by Saturday.
Okay.
Okay. You have done quite well the intraoral assessment. Okay, but I need you to talk a little bit faster and organized, okay? Start always with the name of the photo, then the oral hygiene, complete set of teeth, okay? And as you have mentioned, that the patient in mixed dentition was very smart if use a stage of dentition, okay? And the important intraoral features, okay? You need to be fast. You have done the panoramic X-ray so well, okay? But please start with the 3 Ps first, okay? Presence, pathology, and position, then the root and bone level, condyle, angle of the mandible, and the sinus, okay? 8 points, memorize. You are going to talk about 8 points, okay? So here we have a complete set of teeth from 7 to 7, even the 8s starting to appear in their sockets, right? Because according to Boulanese, the 8 starting appearing in apogee from age 8 to 14, okay? Then the pathology and the position of the teeth. Okay, this was very smart of you that you have mentioned also the stage of the dentition, the patient in a mixed dentition. Okay. The lateral cephalometric, you always forget, Rahim, to state that we are going to talk about skeletal, dental, soft tissue, and CVM. This is how I'm starting my answer. Okay. And when you talk about skeletal, you have to state the skeletal EP using what? SNA, SNB, and AMB, and vertical MMP angle or lower anterior facial height. You have to confirm by all of this. So here, when I ask you, you are going to state that this is a lateral cephalometric radiograph. I'm going to talk about skeletal, dental, soft tissue. The skeletal here, the patient is class 3, confirmed by AMB, D2 decrease of SNA, okay? And confirmed also by WATS. And the patient had decreased vertical dimension confirmed by MMPA and lower anterior facial heights. Okay, and here's a patient in CVM2. Okay, start to be concave, CVM2. Okay, not 1. Okay. The remaining growth around in CVM2, okay, we are here eligible to treat any maxillary deficiency, okay, by using the face mask, as you have mentioned, okay? I have 10 years old, okay? And it considered as the prepubertal growth. The problem list, you didn't do it quite well. I don't know why, okay? Pathology, skeletal AP, you have here skeletal class 3 patients, okay? What about the vertical? You always forget, even in the summary, to tell me, okay, the patient has increased or decreased the vertical dimension. In your summary, you have mentioned all that YA 9.5 male patient fit and with complaining from I can't bite on my front teeth, complicated with class 3 incisor and skeletal base class 3 with decreased vertical dimension. Don't forget the vertical growth pattern in your summary and in your problem list. Okay, Rahim? Then you are going to tell the most important dental factor first. Okay, like posterior crossbite, okay, anterior crossbite, okay, and the class 3 incisor, and so on. And then by the end, you have to mention the soft tissue. The patient have concave profile, protrusive lower lips to the E-line, and so on. The aims and the objective. They keep, in last exam, they managed to ask one of my candidates the problem list in 3 cases out of 4 and the aims and objective, okay? This is way how we collect mark. We need to answer all the basic questions, okay? And also you need to state some evidence. You didn't manage to give me any evidence, okay? You can give me in the extra oral assessment some evidence, like Gonzalez, like Arnett, like Foster, okay? This is how you are going to gain the extra mark. It will help you actually, okay? In the aims and the objective, you have to maintain the oral hygiene measure, accept and the camouflage of skeletal treatment. In this case, you are going to treat the skeletal discrepancy, okay? By using RME and the face mask. Relief crowding, correct the midline. You have to mention what are your aims here. You will have to look to your problem list and correct everything in your problem list, okay? And by the end, after you have correct all the intraoral features, you have to go for the last three. This is constant in all cases: buccal segment interdigitation, coordination of post-arch, and retain the case by the end of the treatment, okay? When we came to the treatment planning, okay, we have mentioned that we are going to start by the three phases. First phase, I'm going to refer the patient to a hygienist to maintain the oral hygiene measure. And if I have any curious tooth or badly prognosis tooth, I'm going to refer it to GDP to restore or temporize this tooth, okay? To consider it and the treatment if I'm going to extract later on. Number two, okay, you will treat these cases on one phase treatment. Actually, this case doesn't want any kind of fixed pre-adjusted fixed appliance, okay? Phase one treatment using the face mask, okay? Don't get confused about the reverse headgear or the high pole headgear. Headgear is using to suppress or stop or restrict the growth of the maxilla. The other device is called face mask. I know this is common. This is the reverse headgear. To avoid any confusion, just please state headgear or face mask, okay? And face mask used to treat the maxillary deficiency and rapid maxillary expansion first, okay? What are you going to introduce first? Are you going to introduce pulse or you are going to introduce one by one? Okay, to avoid burning the motivation of the patient. So I need first to apply the rapid maxillary expansion for the first 3 weeks, okay, till I gain the amount of expansion I need. Then I'm going to, for the face mask treatment for the 6 to 9 months, okay? And actually, and then you going to maintain the rapid maxillary expansion after closing its hole as a retention from 3 to 6 months. Okay, so then you are going to use the pulse in the same time, but one active, which is the face mask, and the other one is not active. Okay, and the retention here in the rapid maxillary expansion, you're going to maintain for 3 to 6 months until you are done with the face mask. But the face mask, you have to keep wearing it on night wear basis till after the growth has ceased, okay? Or you have going to change it to frontal 3 or to reverse twin block, okay? Is it clear, Rahim? Dupek?
Yes.
Yes, yes.
Excellent. Okay, Lubna and Layla? Is it clear?
Yes, yes.
Okay. What is the face mask and what are the types of face mask? The face mask is a device used, okay, to apply the anterior force directed to the teeth or the skeletal structure by using extra oral source. What are the types? Delaire and Petit. Delaire is starting with D, right? Okay, so it will be the double rod. One of my friends asked, he suggested to memorize it this way, okay? D for Delaire, so double rod, okay? At the sides, okay? What are the advantage? It gives me a good stability and less visible by eye, but one of the most important disadvantage that it's bulky and sometimes it discomforts to the patient during the sleeping and eye glasses, okay? What about the petite? Petite means small in English, so it will be one rod in the middle, okay? The advantage, it's less discomfort during the sleeping, easily adjusted, and actually relative cheap, okay, comparing to the Delaire type. But one of his disadvantage, because it's in the middle of the face, it's visible to the eyes. Is it clear? Is it clear?
Yes.
Okay. When to use the face mask, what are the indications to use a face mask? First of all, according to Mandel, you need to use it before 10 years old. Okay, and in few moments we are going to know why before 10. Okay, class 2 in early mixed dentition, I need to have deep bites. Okay, because the face mask tended to procline the upper incisor. During proclination of the upper incisor, okay, it's shallowing the bite. So I can't start treating a patient with a shallow bite in reverse overjet because it will be more shallower. It tend to end the case by open bite. So I need to have a deep bite case in early mixed dentition from the age of 9 to 10 years old. Okay, don't start earlier. And in growing patient in CVM2, okay? And I need to know that the patient is a true class 3. He can't achieve edge-to-edge relationship. He just, in the RCP, fighting in class 3 incisor. He can't manage to get the edge-to-edge, okay? I need also to have a retrusive maxilla, negative AMP, reducing the value of SNA and also OMB, okay? And it should reflect it dentally and in soft tissue. I have to have obtuse nasolingual angle and the concave profile, retrusive upper lip, okay? And I need to make sure that he have normal or mild prognostic mandible, okay? Because while using the face mask, he's going to get as a skeletal part the maxilla more downwards and forward, allowing the mandible to rotate clockwise, downward and backward. So if it's normal or mild prognostic, I'm not going to changing it from class 3 or class 1 to more of class 2, okay? When it's contraindicated, when I have a large maxilla, so I have nothing growing in the maxilla, I'm going not using. When I have a shallow bite, as we mentioned, because it's tending to going to procline the upper labial segment, and during the proclination of the upper labial segment, it's going to shallow the bite. I don't want to end the case with an open bite. And increase the lower anterior facial height. Why? As I have mentioned early, it's going to pull the maxilla downward and forward, allowing the mandible to rotate in a clockwise rotation, downward and backward. While he's rotating, it will increase the lower anterior facial height. So to start the treatment of face mask, I have to make sure that I have a normal or decrease the lower anterior facial height because it will increase the lower anterior facial height during the rotation of the mandible. Is it clear?
Yes.
Excellent. What causes the failure to use the face mask? When I have a large mandible, okay? When I have a horizontal growing patients, okay, it's going not to work, okay? What are the difficulties? I'm going to use Ya Layla. It's like the headgear, okay? What are the difficulties? Or Dupec, what are the difficulties I'm going to see during asking the patient to wear the face mask? First of all, patient compliance, because it has a pad on the chin. I may have sweating and it may irritate in the chin area, okay? I have to make the patient to wear the elastics, okay? It will cause drooling. To overcome this one, you need to do it cross, okay? Cross elastics, okay? The left and the right and the right and the left, okay? To avoid any injury in the inferior corner of the mouth and the excessive drooling, okay? Is it necessary to wear rapid maxillary expansion with the face mask? Okay, yes, according to Hassan Kim. When we see posterior cross bite, but if we don't have any kind of posterior cross bite, according to Vogt, no, I don't need. Some people here will ask me, what about alternating rapid maxillary expansion? Okay, what is the difference between alternating rapid maxillary expansion and rapid maxillary expansion? Rahim, do you know the answer?
Yeah, alternating rapid maxillary expansion is used to facilitate the action of the face mask. The 1 week it will be, we will activate the hyrax, and the next week we will deactivate the face mask, the hyrax.
For how long? For 10 weeks, okay? First, we are going in the alternating rapid maxillary expansion, okay? This is only disarticulating the sutures, right? Okay, to facilitate the work of the face mask. So I need to make it work for 1 week, activate, and in the next week, we are going to deactivate it, okay? For how long? For 10 weeks. But rapid maxillary expansion, it's using when you have a posterior crossbite and you're going to run it twice per day for 3 weeks, and the weekly follow-up by upper occlusal film and the diastema that will occur from first week. Okay? Is it clear till now?
Yes.
Oh,
Yes.
Layla and Lubna, Abrar, is it clear?
Yes.
أيوة يا دكتور تمام.
تمام. Okay. نشوى تمام.
تمام جدا.
Okay. What is the effect of face mask? And as I have mentioned before, and Rahim, sometimes you ask all the questions and you impress me, and the other you just fail to answer it. Okay, I like when I ask you about the effect of face mask, and well, this is Layla. When you do skeletal, dental, and soft tissue, but you fail to give me the whole answer, Layla. Okay, you need to
Yes.
be organized, please. Just imagine what will happen. Don't memorize. We are here to get how it works, not to memorize for the exam, right?
Okay.
Okay, just imagine what will happen when you are going to place the face mask. Okay, the face mask is using in retrusive maxilla. So it's going to pull the maxilla more forward and downward, causing the mandible to rotate in clockwise rotation, leading to increase the lower anterior facial height. All of this is skeletal, AP and vertical, right?
Yes.
This is how it works. Just imagine how it works. Don't memorize, okay? If you want to memorize, okay, we have 3 points, 2 AP and 1 vertical. Okay? So 3 هنا for skeletal, 3 points. Okay?
Okay.
Dental, okay, we have, as in the definition, what is the definition of face mask? This is applying anterior force to the whole maxillary dentition. It's making the posterior segment to move more forward with me. So the dental will be forward movement of the maxillary dentition, leading to, because the upper incisor was behind the lower incisor. Now I'm going to pull it more forward, allowing tapping of the lower incisors, okay? Proclination of the upper labial segment also. This is why I need to start with a deep bite case, not a shallow bite case. And the mesial movement of the posterior segment, okay? And we may show an anchorage loss as Layla have mentioned, okay? What about soft tissue? I need to remember how it looks like in the before treatment. And the soft tissue
Obtuse.
and obtuse nasolabial angle, concave profile, and retrusive upper lips, right? So after the treatment, what will happen? I'm pulling the maxilla more forward, okay? So the concave profile will be straight. The retrusive upper lip will be protrusive, and the increase in the nasolabial angle because it's supporting by the upper incisor inclination, right? So I don't need to memorize. I just need to get how it works. So now for Layla, could you please
Yes.
tell me what is the effect of face mask?
Okay, so we have 3 effects on skeletal, dental, and soft tissue. Skeletal, there will be anteroposterior and vertical. We have a forward movement of the maxilla backward movement of the mandible, clockwise rotation, downward and backward, and increase in the lower anterior facial height.
Excellent. What about the dental?
At dental, the whole maxillary dentition will go forward. Lower incisors will be lingually tipped. Upper incisors will procline, and lower maxillary teeth will mesial movement of maxillary teeth, and anchorage loss. And for the soft tissue, the profile will be straight, labial angle will be increased, and the lips will be more protrusive.
Okay. Did you manage to memorize all of this in this few seconds?
Yes, I imagined it, like
Yes.
you said.
Okay. So imagining how it would work will help you in the exam. Okay?
Okay.
Rahim, is it easy? Dupac, is it easy?
Yes, yes.
Okay. So when I ask you, Dupac, what are the effect of the face mask? What will you say?
The forward movement of the maxillary teeth.
Skeletal, dental, soft tissue, Dupac first.
Okay.
Mm.
Skeletal, dental, and soft tissue.
Mm.
So skeletal, it is the forward movement of the maxilla and clockwise rotation of the mandible, and increase in lower facial height.
Excellent. And what about dental?
Dental, the upper arch will be moving forward. There will be proclination of teeth and anchorage loss. And for the soft tissue, the nasolabial angle will be improved from obtuse to average, and the lips will be protruded.
Okay, and the profile will be?
The profile will be straight.
Excellent, excellent. Okay, but you forget one point in the dental, it is the lingual tipping of the lower incisors, okay?
Okay.
But you managed to do it so well. Rahim.
The effects are divided into skeletal, dental, and soft tissue. The maxillary will be the skeletal effect will be the maxillary forward and downward growth, the downward and backward rotation of the maxilla, and there will be increased lower anterior facial height. Whereas in dental, there will be proclination of the maxillary dentition. There will be lingual tipping of the lower anterior teeth and the mesial movement of the maxillary teeth as a whole. And the soft tissue, the concave profile will be changed into a straight profile and will be more protrusive in nature, and there will be the nasolabial angle also will be reduced because of the forward movement of the maxilla and maxillary anterior teeth.
Excellent, excellent, excellent. Okay. What is the side effect of the face mask? Okay. Anchorage loss, as Laila mentioned, because due to the forward movement of the maxillary dentition, and sometimes actually it leads to the clock rotation of the mandible, okay? Which is when the patient already came to me with increased lower anterior facial height, I consider it the clock rotation of the mandible and the increase more lower anterior facial height as a side effect, actually, okay? So that's why you have to select well the patient criteria: deep bite, growing, CVM2, maxillary deficiency, and decreased lower anterior facial height, and also the mild or mild prognostic or almost normal mandible due to the auto-rotation. That will happen, okay? And according to Mendel, she have stated that there will be no temporomandibular disorder. How to control the challenging I may face while using the face mask? Okay. A challenging, as I have mentioned, so we are going to talk in 3 planes: AP, vertical, and the transverse, right? Okay, AP, what are the challenging? Upper labial segment proclination, okay, which lead to shallowing the palate more. How to overcome, as Rahim have mentioned, we need to use TADS palatally in the incisor region, تمام, to avoid the proclination that may happen, okay? Vertical, I need to control the lower anterior facial height, and this is how I can do when I place the hooks inferior to the center of resistance. Number 3, after using the rapid maxillary expansion, okay, I have to apply more buccal root torque and use of Ross prescription. Why? Because the rapid maxillary expansion will lead to palatal root dropping, palatal cusp dropping of the upper, okay, and also a buccal flaring. So I need to contain all of this by doing buccal root torque, buccal root torque. So the buccal flaring, it will counteract the buccal flaring. It will make the root to be more buccal and the crown a little bit palatal, okay? Or using the Rose prescription, okay? And actually, to gain more buccal root torque, you can use in the Rose prescription the lower premolars, okay? Because it's a 22, and you can put it in the upper. You will gain more buccal root torque by this method. What are the options of consolidation? After the treatment, what you are going to do, I'm going to wear the face mask on night wear basis only till the grass is ceasing. Or I can use one of the functional appliances, reverse twin block or monoblock, okay, or Frankel 3. What do you prefer? I think during sleeping, he might go for the face mask or the Frankel 3. Twin block is not that good. It's a hassle also. What are the limitations of using the face mask? Less than 10 years old, according to Kim. Bashiti have mentioned any gross modification related to the maxilla, either to suppress or to motivate the gross, it will be in CVM2, CVM3 for the twin block, and CVM4 for the fixed function appliance, okay? And less than 9 according to Prophet. Why? Due to the circummaxillary suture. Okay? What are the instructions given during the wearing of face mask, Layla? Okay? I have mentioned it's like the headgear. I need to advise the patient to wear it full time for 4 to 6 months, sometimes up to 9 months. Sometimes he's coming to complain, I can't wear it at school time. So advise him to skip the school time to avoid burning his motivation and cooperation. Skip the school time, and once you hit home, start wearing for 14 to 16 hours per day. Avoid rough sport. What?
Yeah, I said okay, yeah.
Yes, okay. Avoid rough sports. When you are going to play any kind of sport, please remove it first. And during removing it, please don't remove it at home as one piece. No, remove the elastic, then remove the other pieces, okay? To avoid any injury. If we have injury or it fall during sleep, please contact the clinic for emergency visit and get the device with you, okay? If you have trauma or fracture, book an emergency appointment. Keep it clean and rinse. Keep your oral hygiene measures maintained, okay? And give him, as Layla mentioned, reminder tool to increase the motivation of the patient. Give him a calendar motivation, okay? Ask the reception to send up on WhatsApp SMS to remind him to wear his device, okay? Reward him in the clinic when he managed or she managed to wear the face mask for the whole month. When you notice any improvement, reward him and give him positive reinforcement toward it. What are the retention challenging while using the face mask? I need to do overcorrection. The case is starting with a class 3 incisor and reverse overjet. I need to maintain to get a proper overjet and a proper overbite, a positive one, to avoid the relapse. Achieve overjet and positive overbite, long-term retention, and the patient should be favorable grower in the vertical dimension, okay? As we have mentioned, I can't start with increase the vertical dimension, okay? Or a large mandible in AP also, okay? What about the vertical? Okay, I need to do posterior bite blocks. The patient have the whole maxilla is falling in the mandible. Okay, if you are not going to place a posterior bite blocks in your hyoids, okay, to disarticulate and let the face mask and the hyoids work freely. Okay, and also the posterior bite blocks will tend to cause a little bit of molar intrusion and the auto-rotate of the maxilla also, and it will deepen the bite. So it's win-win situation. In the retention protocol, as it's starting as a shallow bite or a class 3 cases, okay, and I use already rapid maxillary expansion, I need to maintain it with a Howley, with posterior bite blocks. Howley to maintain the expansion I have done and the posterior to maintain the overbite correction. Okay, how to control deepening bite? Okay, the face mask should be inferior to the center of resistance, and in few moments I'm going to show you how. Okay, also I need to extrusion of the upper incisor if I'm going for a second phase fixed appliance. Okay, retention by posterior bite block, I need to deepen the bite more, so I need to do a posterior bite block to maintain the overbite correction. If I'm going for a phase 2, I need to bond the bracket more gingivally, okay? Or I may use box elastics, okay? And Delilah, what are the magnitude and direction of force line? Okay, 600 to 800 bilaterally. And according to Petit, we are not going to start with this huge amount of force, okay? We are going to do it gradually, okay? 200 grams for 1 or 2 weeks, then 350 for another 1 to 2 weeks. So the first month, okay, will be 2 weeks, 200 gram, and the other 2 weeks will be 350 gram, okay? And after the first week, I'm going to increase the force till 600 gram, okay, for the rest of the period. So in the first month, I'm going to do it gradually, okay, using elastic light zinc medium, okay, 3/16. In the consolidation period, I'm going to maintain the force for 300 gram using 5/16 elastics, large elastics, okay? What about the force directions? Okay. What about the force direction? First of all, I need, as you mentioned, Rahim, I need to make it past the center of resistance. But the center of resistance, which is distal to the lateral, okay? This is where the hooks will be, okay? Sorry, between the roots of the premolar. Just a second. So The force should be passing through the center of resistance of the maxilla, which is between the roots of premolars. The point of force application, okay, should be distal to the lateral, or if you are going in a mixed dentition phase, which you are, it will be at the C, the deciduous canine, okay? And last one, it should be, and the last one, it should be at 30 degree below, at 30 degree below the occlusal plane, okay? To allow the downward, forward pull of the maxilla, okay? What is the evidence? What is the important evidence of the face mask? The most two important evidence in the face mask will be Mendel and Kim and Haas. If he asks you, is it necessary to use the rapid maxillary expansion with the face mask? So the face mask chapter will be 2 or 3 evidence, okay? What are the evidence? Haas and Kim stated it's okay to use the rapid maxillary expansion while using face mask. Mendel have mentioned that it's okay to use the face mask before the age of 10 years old. Pesciti have mentioned that CVM2 must be noticed to start the treatment of the face mask. And the most important one, when you do the rapid maxillary expansion and how you are going to calculate it, as Rahim mentioned, you are going to do it according to Bishara methods, okay? As Rahim said. So we have 4 important evidence in this session. What are the 4 evidence, Rahim?
Mandal et al. And Bishara.
Mm.
Kim and Kim. Kim et al.
Kim and Haas, okay?
Yeah.
Yes, Mandel have mentioned or have stated that we have to start the treatment early, before 10 years old. Bashetti have mentioned that I have to notice the patient in CVM2. Haas and Kim, it's okay to use a rapid maxillary expansion as long as I have a posterior crossbite, and when you are going to calculate how many millimeter of expansion you need to do in the rapid maxillary expansion, we are going to do it according to Bishara. Is it clear for everyone?
Yes.
Excellent. Okay, and this is only for your knowledge, okay? If you need to go in more depths in the exam, okay?
Can you please tell me Haas and Kim's this thing?
Haas and Kim state, okay, the question was, is it necessary to put rapid maxillary expansion along with face mask? Okay, he said yes, it is necessary as long as we have a posterior crossbite. But if I don't have, I don't have any posterior crossbite, I don't need to do rapid maxillary expansion. Okay?
Okay.
Good. Mendel, she is a woman, not a man, as most of us has figured it out. I thought she was a man, okay, by the name, but she's a woman. Mendel have the most important 3 paper in the face mask, 2010, 12, and 16. Before 10 years old, okay, the face mask will give me the effects dental and skeletal. As we have mentioned, is dental, proclination, maxillary, posterior, upper posterior will move more forward, tapping to the lowers, and proclination of the upper labial segment, okay? A skeletal will be the downward forward position of the maxilla, leading to the auto-rotation of the mandible in clockwise rotation and leading to increased the lower anterior facial height, okay? Okay, just a second, please. Okay, and in 2012, before 10 years old, I have also the both effects, dental and the skeletal, but adding that it will gain 70% of positive overjet, and I have no temporomandibular disorder. In 2016 of the same paper, okay, she stated that the using of the face mask will reduce the chances to orthodontic surgery, okay? And the overjet, instead of 70, it will be 68, okay? And in a long term, I may lose the skeletal effects in a long term, okay? And this is the brilliant question of one of my dearest friend and one of the intelligence in the also Part B course preparation, Dr. Ala Gamal. She is the one who managed to put all of these points together, not me, okay? And I'd like to send her my greetings from here. She have mentioned how to minimize the proclination of the upper labial segment, okay? Expansion will increase the arch parameter, and when it's increase the arch parameter, okay, it will decrease the proclination, okay? And I will show you how in a bit. As Rahim have mentioned, TADS palatally by increasing the force will also limit the proclination, and it's done on the patient of 11 years. So it's okay to put mini screws in the patient before 13 years, okay? According to SERV 2020, and this is found in the Preston notes also, okay? And Nance button with the face mask to disturb the force along the palate. And also you can use a ROS prescription because it's positive 12, not positive 17, okay? Extraction also, and we can retract, so it will limit the proclination, or if you have any Bolton discrepancy or increase the size of the teeth, you can use the IPR. Okay, this is how to show when increasing the arch parameter, it will lead to minimize the proclination of the upper arch. Look here, this is how the arch looked, okay, before expansion, okay, and this is how it look after expansion. The parameters here increased. Here, it will lead to proclination. Now the teeth are more relieved in its position, okay? And this is during expansion, what will happen? We are going to increase the parameter and decreasing the proclination. Where the hook should be located, okay? I have separate 3 places, okay? And this will show me what exactly I need. Do I need the whole maxilla only to move in a forward or down as a bodily movement, or sometimes I need a clockwise rotation and to deepen the bite, or anti-clockwise rotation of the maxilla to shallow the bite, and so on, according to the case. So you need to know what exactly you need from the face mask, and depending on that, you are going to know how to locate your hooks, okay? Through the center of resistance, okay, it will tilt the maxilla more forward and downward as a bodily movement, no moment and no tipping, because I'm going through the center of resistance. If I place the hooks, place the hooks in front of the center of resistance, what will happen? And if it's posterior to center of resistance, what will happen? Okay, let's see together what will happen. Okay, this is the line of force, okay? This is the line of force, and okay, this is a little bit fast. Let me, okay. Okay, this is the center of resistance of the maxilla. Where is the center of resistance of maxilla, Rahim?
Between the two premolars.
Yes, between the 4 and 5, right? And the line of force application will be applied where? Distal to the lateral or at the C, right? Here, right? And
Yes,
the elastics will be in 30-degree, okay, to facilitate the downward forward of the maxilla. So when I put the elastics and the hooks in the center of resistance like here, the maxilla here will move downward and forward as a bodily movement, right?
yes.
Okay, and this is how it works. Okay, more forwards and downwards. Okay. Is it clear now? What will happen if I place it in front of the center of resistance? Where is the center of resistance? Okay, just a second. I want to show you something first. Okay, the hook here was near the center of resistance, right? The lock here, okay, it's near the center of resistance. If I applied it here, it's near, okay? The second one will be anterior to the center of resistance. Okay? It's anterior to the center of resistance, right? In front of it. What will happen? Okay? Where is the center of resistance? Between the 4 and 5. Where is the force application? Distal to the lateral or at the C. Okay? Where is I going to place it? In front of the center of resistance. Okay? In front of the center of resistance. So what will happen? Okay? Will happen clockwise rotation of the mandib of the maxilla and downward and forward, which leading to deepen the bites. Because I'm in front of the center of resistance. So I have both. I have the rotation moment and I have the effect of downward and forward movement. But is it okay to put it in front of center of resistance? Yes. One of the rules to use the face mask, as I mentioned earlier, I should have what? Deep bite, right? Because the effect will be the proclination of the upper labial segment and leading to shallowing the bite. Right. If I have a shallow case bite, should I leave it without any kind of treatment? No. Okay, I can use the face mask. Okay, I can place the hooks and the elastic in front of the center of resistance. It will help me to auto-rotate the maxilla more downward and forward in a clockwise rotation, and also it will move the maxilla, okay, more in front. The auto-rotations that happen in a clockwise rotation, as a dental effect, it will deepen the bite. It will what? Deepen the bite. So it works or it doesn't work, Rahim?
It will work because anyway the maxilla is rotating clockwise.
Yes, so I can use the face mask in a shallow bite cases, but all I need to do a little bit of modification, right? I needed to place it in front of the center of resistance to allow the moment I'm going here to use the side effect that happen because I'm away from the center of resistance as one of the advantage to treat another malocclusion I have, which is the shallow bite, right? Type.
Yes.
If I have, okay, a deep bite, severely deep bite, and I need to shallow the bite more, okay? What will I do? I'm going to place the hooks posterior to the center of resistance. Where is the center of resistance? Between the 4 and 5. Where is the force action? It should be distal هنا in front. No, now it's posterior to the center of resistance. So what will happen? okay? At the moment, it's going to rotate the maxilla in what? In anti-clockwise, right? In anti-clockwise, leading to upward, okay? Upward rotation of the maxilla and open the bite. And also, it will give me the downward and forward movement of the maxilla. Downward and movement, okay? Is it clear? Okay. This is how it looks like. It's going to move a little bit forward, downward, okay? And because it's behind the center of resistance, the maxilla will auto-rotate in anti-clockwise, leading to opening the bite more. Is it clear for everyone? Is it clear for everyone?
Yes.
Abrar, Layla, Lubna, Nashwa. Is it clear?
Yes, it's clear.
Okay,
أيوة
Dupek,
يا دكتور.
Dupek, is it clear?
Yes, yes, ma'am.
Okay. Rahim, what is the mechanism of growth of nasomaxillary complex? Why should I need to start the treatment early, before 10 years old? Why? Okay. Why I'm going to do so? Because at the age of 10, 95% of the circummaxillary suture will be closing. Okay. And the remaining 5 will be closed at the 15 years old. This is why when I finish the treatment of the face mask at 10 years old, I need to retain it till it stopped growing by 15. Okay, and this is called by the primary displacement. Okay, what about the secondary displacement? The secondary displacement will happen due to the spheno-occipital syndrosis, which is closed by 16 to 17 years old also, okay? I need to maintain all the result till the growth is ceased. And also the third mechanism by the bone remodeling, by adding bone at the posterior part and the lateral part of the skull and leading to the anterior resorption of the anterior part. And we will know all of this in the gross lecture later on. Okay? So when I ask you what are the mechanism of growth of nasomaxillary complex, you are going to state by primary displacement by the circummaxillary suture, as it's mainly closed by 95% by the age of 10, as Prophet have mentioned, and at the remaining 5 will be the age of 15, and secondary by the spheno-occipital synchondrosis, and finally by the bone remodeling, by adding extra bone at the posterior and the lateral part of the skull and resorption in the anterior region of the maxilla. Is it clear? Is it clear?
Yes, doctor.
شكرا.
Yes.
Thank you. Okay, today we have done with the face mask. Okay, in our next session, which is the next Monday, we are going to have another unseen, and I'm going to tell you about the topic to study 12, Dupek and Rahim. Your exams are near. Okay, it will be about class 3, and then we are going to explain in detail the whole chapter of class 3. Okay, anyone have any question related to this part?
No.
Everything is clear, Dupek and Rahim?
Yes, ma'am.
Yes, yes.
Abrar, Layla, Lubna, Nashwa, everything is clear?
Yes, doctor.
Yes.
Okay, Lubna. I don't know Lubna is here. Nashwa. Is it
Thank you, doctor. تمام.
Tamam. Okay. So please today study the face mask and class 3 treatment, because in the next week we will have Monday, Tuesday, we are going to talk about class 3 in more detail. Okay? Thank you and see you next week. Plus, please study hard the diagnosis part once more, Rahim, plus face mask and the class 3. Okay?
Yeah.
Okay. Have a
Thanks يا دكتور.
Afwan, thank you. Have a good, lovely day and see you next week, inshallah. Bye bye.